My name is Dr. Birungi Mary. I'm a gynecologist, stroke obstetrician, and I'm also a laparoscopic surgeon. I work with Emmanuel Medical Center in Tebe. I'm going to talk about antenatal care. Being a gynecologist and obstetrician, I see mothers who are pregnant almost every day. I attend to pregnant mothers with different issues, with different complications, and I want to start by defining antenatal care. Antenatal care in simple terms is the care given to pregnant mothers during until the time when they deliver, to make sure that the mother and the baby are all healthy at the time of delivery. There are several objectives for antenatal care. There are several reasons why mothers should come for antenatal care, and some of them include screening them for high-risk pregnancies so that we are able to identify the complications early, to attend to complications, and to prevent complications. During antenatal care, it's all the 9 months, okay? Wherever you meet a mother, wherever you come in contact with the mother, you are supposed to continue screening for complications, and also to educate these mothers to know what they should expect. Some of them get minor changes and they don't know what to do, so they run to hospitals all the time. Whereas if they are well educated, they will be able to know that those are some of the changes that take place in pregnancy, and they can be able to deal with them. So, when should one start antenatal care? The mothers, once they realize they are pregnant, we encourage them to come to hospital as early as possible. Within the first trimester, at least first 8 to 12 weeks, the mother should have a contact with a health worker. And during this antenatal visit, the first one, we do a lot of tests on them. We screen them. We do some blood work. We check for HIV, we check for hepatitis, syphilis, their blood group, the amount of blood they have, because of several reasons. For the sake of the mother and the baby being healthy at the end of the pregnancy. The number of antenatal visits we advise, according to WHO, they advise a number of 8 visits, okay? At least contact with a health worker. It may not necessarily be a gynecologist or an obstetrician, but at least contact with a health worker. Within the first 8 weeks to 12 weeks, there is 1 visit. We repeat again at 20 weeks. We can repeat at 26 weeks, at 30 weeks, 32, and 36 weeks, at least a minimum of 8 visits if the mother doesn't have complications. When we first come in contact with the mother, we have to fill in an antenatal book. An antenatal book is something like this. This carries the information of the mother, okay? And all this book looks for the risks, okay? We consider the mother's age. We consider the gestational age, how many babies has she delivered before, and what was the mode of delivery. Did she get any complications during that time? Does she have any chronic disease like heart disease, like asthma? Is she a sickler? All that comes in this antenatal book. And along the way, we do preventative measures. Like now, Uganda being endemic for malaria, we give all antenatal mothers fansida at some stage. We deworm them. We also give them calcium. We assess them wherever they come. You are looking for the risks, okay? And why we do blood count in each trimester, we should look for the full blood count to rule out anemia, because anemia is #1 cause of maternal mortality, indirectly, and fetal mortality. Okay, because in antenatal we may not know which mother will bleed during delivery, whether she will deliver with a Caesar. If the blood is low, then she can get sepsis, and even the baby's well-being. She can give birth to a small for age baby. The baby's weight may be lower than expected because of anemia. So we try to fight anemia, and we give them hematemics, iron. Please, when you are given iron tablets, take them, because that's the way of fighting anemia. And also dewormers are necessary because the worms are one of the causes of severe anemia in pregnancy in the population. So that's why we give them those drugs. And also during the antenatal, when we discover that somebody is HIV positive, we give them drugs, ARVs, to prevent prevention from the mother to the child, okay? So that we have HIV negative babies. And when we start the ARVs in antenatal, that means we've started them for life. We don't say that now after delivery, stop them and lead another life, okay? When we start them, it's for life. So during this first antenatal, we assess the well-being of the mother. We look at the gestational age and the EDD. Then we do those investigations and also educate them about the benefits of antenatal care to the mother. Okay. Then the other visits, like when she comes in at 20 weeks. Oh, sorry, before that, during this initial visit, the initial contact, we also do an obstetric scan. This scan is essential in that it will give us the expected date of delivery. We will know the gestational age of the mother, and most important also, we will know where the location of the fetus is. That's how we come to diagnose ectopic pregnancies early enough to manage them before the tubes rupture. Then the most important scan that we do also is at 20 weeks. 18 to 20 weeks is very important to do a scan. At least if the mother doesn't have the money to do the first scan, we can wait. But 18 to 20 weeks, because this one will show us the abnormalities on the baby. The anatomy of the baby, we are able to see it at 20 weeks. And also the expected date of delivery, then the other things like the placenta, the location of the placenta, the amniotic fluid, we'll be able to see them clearly at 20 weeks. And some mothers are also interested in knowing the sex of the fetus, so it can be seen at that time. However, there are some special tests that can be done apart from the routine. Like if we suspect sickle cells, if we suspect congenital abnormalities, diseases like rubella, we can do that. Sometimes mothers also have thyroid problems that can also interfere with the pregnancy. So those ones we suspect to have thyroid issues, we also do the special test for the thyroid. And also there are some diseases that come up as the pregnancy progresses. Like we screen for sugar diabetes in early pregnancy, but between 24 to 28 weeks, we are supposed to repeat the blood test again to rule out gestational diabetes, which can be a cause of maternal morbidity and mortality, as well as the fetal mortality and morbidity. At Emmanuel Medical Center, after the antenatal period, then we receive these mothers in labor planning for delivery. So for a normal delivery, it can cost you between 800 to 1.2 million, depending on several factors. But we usually provide a mama kit. The mothers should not buy a mama kit. Yeah. And we have also VIP rooms. A normal delivery VIP will cost you 1.5 million. However, there are mothers who come in for elective scissors. Their deliveries are planned for several reasons. Those ones, if it's a straightforward elective scissor in a private room, it's 2.5. But if we put you in VIP, then it will go for 3 million. But that will include the meals as well. The drugs, post-operative care is included in that. And also the first review for after delivery, the postnatal review after 6 days. But if a mother starts with or you try to have a normal delivery and along the way you fail and you find that you have to go for cesarean section, it can go between 2.7 to 3 million. And we also advise mothers, those who are not on insurance, we encourage them to start depositing some money during the antenatal period before the due date, so that it's an advantage to them. They find that after delivery they can be having less money to pay at the end of it all. So the initial antenatal visit can go for about 200,000 because of the several tests involved. We do 8 tests and also a scan involved. We have a normal delivery in a private room. We have a normal delivery in a VIP room. We also have elective cesarean sections in a private room and also in a VIP room. We also have mothers who can come in labor. Along the way they fail and they find themselves going for a cesarean section. When the mothers come in, they can book for either delivery or cesarean section or antenatal care. We have records where we keep our mothers and wait for them on those agreed days. So mothers, we advise them to start preparing for labor as soon as they start attending antenatal care, because we know that eventually they will get into labor. And one of the things we advise them is having a healthy diet, taking their supplements as given by the doctors, coming for routine checkups, and during these routine checkups, we start talking to them, preparing them for labor. And one of the ways we tell them that when it comes to 37 weeks, if you are to deliver at our facility, please be near. Don't go to like far away from the facility. And you don't need to come with the mama kit. The mama kit, you'll find it here, but you need your personal belongings, okay? And also for the baby. And then we encourage them to walk around, not to stay in one place for so long, to avoid strenuous exercises that can cause backaches, that can cause preterm labor, and if possible, if the mode of transport is a border, we advise them to go on borders, but slowly, not to bump them in potholes, okay? Because potholes can lead to bleeding in labor and they can cause trouble. And we also advise them on the danger symptoms and signs. Like if a mother's face starts swelling, if her hand starts swelling, then she has to run to the hospital. Or if she finds herself with that one leg is swollen, is painful, she can walk with difficulties, please run to the hospital. And we encourage them to continue feeling for the fetal movements. Mothers have to feel the baby moving. At least in an hour, the baby should move at least 3 to 4 times. If she doesn't feel the movements, we encourage them to eat something or to drink something sugary, and then leave whatever they are doing, the rest for 1 hour. That baby should be able to move. If the baby does not move, please come back to the hospital. And we encourage them to take morning and evening walks. There are routine tests that are done according to WHO, and I'm going to mention them below. We do full blood count to look specifically for anemia, because anemia is number one indirect killer of mothers, causing maternal mortality and morbidity. We do full blood count, blood group, because it's very, very important to determine the blood group of a mother. Those who are rhesus negative, they are given anti-D, and those who are rhesus positive, the blood groups are known there, because any time a mother can present with uncontrollable bleeding, and then you know what to do. Or we do urinalysis, because here we look for pus cells, that's infection, we look for protein, blood sugar, because infections themselves can lead to preterm labor, they can cause abortions, so it's important. And also when we detect like glucose in urine, we have to look for sugar in the blood also, because maybe the mother was diabetic and it was never diagnosed. And also proteinuria in urine is not a good sign. We will have to look for that, is she getting pressure related complications. We do HIV to all pregnant mothers, so that in case a mother is HIV negative, we give them the ARVs to prevent transmission, maternal to child transmission of HIV. Then hepatitis B, we look for it because it can easily be transmitted to the mother. And those mothers who have active hepatitis B in pregnancy, we make sure that at birth the child is given immunoglobulin against hepatitis B, and also immunized against hepatitis B. We look for malaria, because malaria is one of the causes of maternal mortality as well as fetal mortality, because of the complications, because it can hide in the placenta and can cause unseen complications. That's why we even give mothers Fancida before they present with any malaria symptoms. So syphilis, we also look for that because it can cause congenital abnormalities to the baby, abortions, preterm deliveries, okay? And then a scan, an obstetric scan. This scan, if all is well, we do only 3 scans in pregnancy: in the first trimester, at 20 weeks, at 32 weeks. And each one of them, like in the first trimester, we are looking for the gestational age, we are looking for the EDD, the location of the baby, and the number of the fetus, and the number of the fetuses in the mother. The second one is looking for the anatomy of the fetus. Okay, that's about 18 to 20 weeks. Then we have the one at 32 weeks, because we are preparing the mother for delivery. Okay, you want to know the presentation, the placenta, though you already know it, but you want to confirm how is it. You want to confirm the amniotic fluid, the weight of the baby. Is this baby growing according to the gestational age, or are there other problems? What type of food should mothers have during pregnancy? So we advise our pregnant mothers to have a balanced diet. They should have the protein, the fat, the carbohydrate. But what we fear most is alcohol, cigarette smoking, and drugs. Okay, these local foods of ours in Uganda, during pregnancy, we encourage the mothers to have a balanced diet, to take rest, to have their hygiene, personal hygiene, and to continue with their normal routines, unless if their type of work they are doing, we see it becoming a problem to the development of the health of the mother and to the baby. And also we advise them not to just buy tablets or drugs anyhow. Okay, when they find themselves sick, they should come to a health worker so that they are examined, so that they are checked, and then given the right drugs. At Emmanuel Medical Center, we are able to do normal vaginal deliveries as well as cesarean sections. We have a labor ward that's open 24 hours with the doctors and obstetricians around, and midwives. Okay, so when a mother is admitted in labor, the mother is assessed and monitored according to WHO standards. We do a pathograph, and if we find that a mother is going to deliver normally, we give them a chance, they deliver. And those ones we find that they need cesarean section, we also have a theater which is open 24 hours a day with an anesthetist and the support staff for operations. Emmanuel Medical Center is located in Manyago, Seseview Road, Plot 14. We are behind Antenatal Beach. If you are coming to Emmanuel Medical Center, if you are coming from Kampala, you can drop off at Katabi stage. You'll find a signpost and take the left turn. It's a Tamaka Road. Then along the way, you'll find a signpost for Emmanuel Medical Center, and you'll find us at Manyago, Seseview Road. We provide outpatient services and inpatient services. We have like 3 doctors always on duty and the nurses, but if the work is overwhelming, we always get others to come in and help us. And at Emmanuel Medical Center, we have in and outpatient department. We have daycare cases whereby somebody can come in, is treated during the day, is given a bed rest, and then they go home later when they feel well. And we also have admissions. Our rooms are private. They are all self-contained, and they have 2 beds, one for the attendant and one for the patient. At Emmanuel Medical Center, we also have a general ward. This general ward is for the people who may not be able to afford the private rooms, but when they need a medical service. Okay, we treat them the same way the patients, like the patients who are in the private rooms. We give them the same medication, we give them the same care, only that they are sleeping in a different room. Being a gynecologist as well as obstetrician, there are several surgeries that we can do apart from a cesarean section at Emmanuel Medical Center. We can do myomectomy. Myomectomy is whereby we remove the fibroids from a mother's uterus and leave the uterus behind so that she can continue. If she wants to have children, she can continue to have the children as desired. Some others have ovarian cysts. but not every ovarian cyst should be operated. We look at the sizes. If the size is that for operation, then we can also remove it at a manual medical center. And doesn't mean that when the cyst is removed, the ovary has to be removed as well. No, the mother can still have a cyst removed and her ovary spared. When the cyst is removed, the ovaries can be left behind, because those mothers usually are young mothers who still need their ovaries for reproduction as well as for hormones to continue being women. And mothers who come in with the ectopic pregnancies, we can still remove them from here. You can have the operation here and they can get well. Ectopic pregnancy, it means that the pregnancy is outside the uterus. The pregnancy has to be implanted in the uterus. But if it's implanted in the fallopian tubes or in the ovaries or in any other area apart from the uterus, then that's an ectopic pregnancy. And the fetus can only grow in the uterus. It cannot grow outside the uterus. So it's unfortunate that many mothers get to be diagnosed when the pregnancy has already ruptured, okay, and you cannot save the tube. But if it's diagnosed early, the pregnancy can be saved and the mother's tube, the tube can be saved to continue with the reproduction, okay. The possible causes of ectopic pregnancy, we have blocked tubes are the major cause of ectopic pregnancy, and blocked tubes usually come in because of sexually transmitted diseases. That's the number one cause of ectopic pregnancies. That's why we advise mothers, we advise couples, wherever they have challenges in that area, to seek medical advice. At a medical center, we can also do hysterectomy. Hysterectomy is whereby you remove the uterus of a mother for any medical condition. And when we remove the uterus, it doesn't mean that we've removed the ovaries. If the ovaries are left in place, still they will serve the purpose of having the hormones that the mother needs to continue with life, okay? But only thing she cannot do, she will not have periods again, and she will not be able to carry a baby again in her womb. She won't become pregnant again. What are the reasons why we remove a mother's uterus? Okay, one of them could be like a postmenopausal woman, a woman who stopped having periods, like a woman of 55 years who stopped having periods like 5 years ago. If she comes in with vaginal bleeding, then in most cases you have to look for cancer. Cancer is number one cause of removing the uterus in a mother of postmenopausal age. We also remove uteruses in mothers who are, like a mother comes in, she delivers her baby very well, and after that she gets postpartum hemorrhage, whereby the bleeding cannot be controlled. So for us to be able to save the mother, the uterus has to be removed. But in such cases, when we remove the uterus, we leave behind the cervix. And so that mother, we leave behind the cervix and the ovaries. Sometimes the mother can come with fibroids that are very big, and you find they are very big and they are very many. So in that case, you have to consider her age, you have to consider the fertility desire, and if you see that you cannot save the uterus, then you remove the uterus. How safe is the removal of the uterus from a mother? Here we have to consider the age of the mother first, okay? And the condition why we are removing the uterus, okay? The use of the uterus in any woman is to carry the pregnancy, okay? After that, there is no other function of the uterus. It's the ovaries that make women women, because they are the ones that secrete the hormones that we need to be women. So removing the uterus, it will not affect your life, that you may be life to shorten your life expectancy. It will not shorten that, and you'll still be sexually active, because the cervix, the vagina will still be intact, but the cervix and the uterus will be removed. So the desire for sex will still be there, because the hormones will still have the hormones The services, as Emmanuel Medical Center, we offer a wide range of services in both outpatient and outpatients. We offer pediatric services, medical services, obstetrics and gynecology, as well as surgical services. But if we find that a client comes to Emmanuel and we are not able to offer that service, we usually refer those patients to the appropriate centers where they can be able to get the services they need that may be beyond our facility. We have a pharmacy. At Emmanuel Medical Center, we also have a pharmacy that's open 24 hours. We have patients who can walk in to get some drugs. Maybe they have been prescribed somewhere and they are not there, they can get them. But we mainly serve our patients here at Emmanuel. When the doctor has prescribed the drugs, the client picks them from the pharmacy and they pay according to that service accordingly. We also have ambulance services that are offered 24 hours. We have patients who come in here and we find that they are beyond the facility. Those ones we can transfer them to any hospital of their choice. The nearest to us is Chisubi, but those ones, Chisubi Hospital, but the other clients prefer to go to other hospitals in Kampala, so they pay for the ambulance services and they are delivered to the hospital of their choice. Sometimes we have patients who call us mainly in the night or public holidays, and we pick them from their homes to Emmanuel Medical Center, to a center of their choice, and we also do that at a fee. Dental services are also available at Emmanuel Medical Center. We have a dental x-ray and many dental services here. And sometimes if we find still that it's beyond us, we can call in the dental surgeons or we can refer them to the places where they are and they still access the services. Laboratory, our lab is open 24 hours. Many tests we are able to do them at Emmanuel, but a few that we are not able to do, we outsource them. And if we outsource them, we will tell the client, please come at this time, your results will be ready. We sometimes do histology, like if you operate a patient and you find a tissue, we don't throw it away. We have to take it for analysis. Those ones, we take them to a histology lab and then we get the results within 2 weeks. Then you communicate with the patient to come and pick their results. And also in our laboratory, because we have to do quality control, there are some labs we attach to where we do our quality controls from, so that we don't give false results to our clients, and also helps us to know how we stand as a lab, where should we improve, which machines do we need, which machine is working well, which one needs servicing. Theater services are also available at Emmanuel Medical Center. They are available 24/7. When somebody comes in and it's an emergency or it's an elective case, we usually plan and do that, or we usually do as emergencies because we have a team. Theater is teamwork. We have the anesthetists, the assistants, the surgeons, we have anesthetic machines and all the other machines that are necessary to make sure that the patient is safe while in theater. Do we need to have appointments for us to go to theater? Sometimes for elective cases, for cold cases, we can book them and plan for them properly. But being a facility, a medical center with the theater services, sometimes patients just walk in as emergencies. For example, if somebody is hit by the roadside, if somebody has like any case that's an emergency, we can still attend to it at Emmanuel Medical Center in theater. We also have scan and x-ray services, radiology department, which is active. Patients usually walk in, some come in from out just to do x-rays or scan and they go back to their doctors. Some of them, we have them at Emmanuel and the doctors recommend the scans. So we have scan services that can do all types, whether obstetric, gynecology, whether any other surgical case that requires scan, we can still do it at Emmanuel Medical Center. Some of the gynecological scans we can do here. We can do pelvic scans. when you are looking for pelvic masses, when you want to look at the ovaries, when you want to look at the uterus, is the mother okay? Does she have an infection? But also we have the transvaginal scans. We find that some conditions are better seen, are better understood, better described by transvaginal scans. For example, if somebody has abnormal uterine bleeding, if someone has polyps, small lesions in the womb, we can do a transvaginal scan because the organs are very close to us, and also you don't need to drink water, so it will take less time. Yeah, and also transvaginal scans are very important when we are dealing with someone with infertility, because they will give us a clear picture of how is her uterine cavity like. Does it have polyps? Does it have any growth? Does it have synechiae? So if we are looking for fertility issues, we have to do transvaginal. And also transvaginal is also very important for tracking the follicles, the eggs of this mother, assuming she has given her medication for ovulation induction. We'll be able to track the follicles better with the transvaginal scan, and also look at the endometrium.